Hello everybody. Today let's discuss about the abnormal uterine bleeding. Okay. So it is actually divided into structural causes and non-structural causes. So for a better understanding, I have done a diagrammatic representation for a better understanding, and we will also learn what could be the causes of this abnormal uterine bleeding, and in that what all we have to consider, like history, and whether it is endocrinological etiology or if there is any bleeding patterns. And we also should confirm about the pregnancy bleeding or not, and also we have to do some of the investigations and management. Let's discuss in this video about this abnormal uterine bleeding. So the abnormal uterine bleeding, it is divided into the structural causes and non-structural causes. So the structural causes is palm, and non-structural causes is divided as coin. So if we see the structural causes, that is present inside the structure of the uterus. So if we say P for palm, A for adenomyosis, L for leiomyoma, M for malignancy, or we can also consider the endometrial hyperplasia as well. So P for polyp. The polyp is something that is protruding inside the uterine cavity and which is causing the intermenstrual bleeding. So if they have the normal regular menstrual cycles, and in between those cycles if she is bleeding in between the cycles, then we have to think about this polyp. So polyp we should consider if she is having any intermenstrual bleeding. Next thing is adenomyosis. In adenomyosis, there is an endometrial glands and stroma that grows within the myometrium of the uterus, and because of this, it looks like a globally enlarged uterus. So globally enlarged uterus, which is corresponding to the adenomyosis. So where we have to differentiate between the leiomyoma and adenomyosis. Leiomyoma is a smooth benign tumor that develops in the uterus. So it is again divided into subserosal, intramural and submucosal. So according to FIGO classifications, again it is divided into several subtypes. So we have to go through that FIGO classification based on their location and involvement of the structures. So in this adenomyosis, there will be heavy menstrual bleeding, and in case of leiomyoma also there will be an abnormal uterine bleeding. Next thing is that we have to differentiate it to the malignancy and the hyperplasia. Most of the women, they come in the reproductive age group as the endometrial thickness keeps growing like this. This is a normal thickness and it keeps growing like this, and it results in the endometrial hyperplasia. So whenever there is an endometrial hyperplasia, we need to differentiate whether it is a with atypia or without atypia. If it is without atypia, then you don't have to be worried about it. It will be get treated either with the medicines or we can go for the surgical management. If it is with atypia, then we have to think of the malignancy. So we should be little careful about this malignancy. Then that time we have to go for the total abdominal hysterectomy with bilateral salpingo-oophorectomy. While we come to this coin, which is a non-structural causes, C for coagulopathy, O for ovarian dysfunction, E for endometrium, I for iatrogenic, N for not yet classified. So if the patient is having any kind of a bleeding disorders, then we should consider it as a coagulopathic bleeding disorder pattern type of abnormal uterine bleeding. Next comes the ovarian dysfunction. As I said that the endometrium gets hyperplastic. So why is that the endometrium is getting hyperplastic? Sometimes it is because of the obesity, the excess estrogen it keeps on working on the uterine lining, the endometrium, and it gets thicken, and it results in the endometrial hyperplasia, and the woman will complain about this abnormal uterine bleeding. So in case of ovarian dysfunction, so another cause of this endometrial hyperplasia is this ovarian dysfunction. Like other causes, polycystic ovarian disease, one of the cause, because of this hormonal imbalance, because of the less deficit or less amount of the progesterone that is present in the PCOS, it results in the continued exposure of the abnormal estrogen, results in the endometrial hyperplasia. So ovarian dysfunction, next endometrial causes, next is iatrogenic. For example, if we have kept any kind of a copper T inside the uterus, it results in the menstrual bleeding. If somebody has gone with the copper T insertion and they are having a heavy menstrual bleeding, then they should visit the doctor to rule out whether it is because of the copper T or is some problem going with that. So you need to visit a doctor immediately. Then another cause is not yet classified, like it includes the cesarean scar defect. For example, if the cesarean scar, whatever that the doctor has repaired, if it is not closed properly, or from that scar site it will start oozing out slowly. That is one of the reason that I could say, but it is still kept it under a not yet classified cause. So whenever the patient presents to us with an abnormal uterine bleeding, we need to consider whether it is a structural cause or it is a non-structural cause. If it is a structural cause, then think about a polyp, adenomyosis, leiomyoma, hyperplasia or malignancy. If it is a non-structural cause, then you think of about the coagulative disorders or PCOS, or because of the endometrial hyperplasia, or because of any copper T insertion. One thing you need to be remembering is that any copper T insertion or any Mirena device insertion, yes, it will cause irregular bleeding for 1 or 2 months, but then it will subside and it will cause oligomenorrhea or hypomenorrhea in case of LNG-IUS. But in copper T, the bleeding will be little more. But if it is more severe, like passing clots, and it is even more severe, then you should consult your doctor. So iatrogenic and not yet classified. So any kind of an abnormal bleeding, you have to think of the age first. So if it is a early age, then think of about the coagulative disorders. If it is in between, like teenagers, we can think of about the ovarian dysfunctions and all. And also in the reproductive age, we can think of the pregnancy, we can think of the polyp, we can think of the adenomyosis, we can think of the leiomyoma, and sometimes it can be a cause of ovarian dysfunction and hyperplasia. So every time rule out the pregnancy. So better you go with the UPT, simple UPT test. Next, in the history we need to ask about the endocrine disorders, like if they have a thyroid disorder or it is an endocrine disorder like diabetes mellitus. So most of the time PCOS can also cause this endometrial hyperplasia or abnormal uterine bleeding could be a cause. And next thing is bleeding patterns. We need to know whether it is a heavy menstrual bleeding or there is a passage of clots, or if there is any kind of bleeding that is associated with the menses, like intermenstrual bleeding, like that. And we should also be sure that it is from the uterine origin, and it is chronic in nature. So why we should confirm that it is from the uterine origin? Sometimes it could be in cases of the vaginal tears also, there can be a bleeding, abnormal bleeding could be there. In cases of any cervical trauma, there could be a cause of bleeding. So we need to rule out, and mostly we should think that since how long are they suffering with this abnormal uterine bleeding? Is it from 3 months or is it from 6 months? So based on its nature, like is it acute or chronic. Based on that we need to decide through which management we can manage the patient treatment about this AUP. The next thing is that we can go for the either a urine beta HCG or the serum beta HCG, because sometimes without any malignancy, sometimes it could be an ectopic pregnancy also, where we need to rule out. Next thing is investigations. In investigations, we have to go with the lab parameters. Normal coagulation disorders we need to check, and transvaginal sonography. Why transvaginal sonography is particularly we are suspecting of AUB, right? So mostly it is either of the uterine origin or from the ovarian origin or through the cervix or cervix, from anywhere it could bleed. So through TVS, the visualization of these organs, pelvic organs, will be very clear. And uh, SIS and hysteroscopy. Hysteroscopy, you can see clearly this endometrial thickness, the polyps that are present inside the uterine cavity, and we can also see the uterine cavity. Is there any abnormal cavity is there, or what is the thickness inside it? Whether any abnormal pathology is present, or any fibroid is there, or a polyp is there, we need to rule out. Next thing, if there is a biopsy, we can also go with the hysteroscopic. Polypectomy we can do at the same time. We can perform a diagnostic and we can also treat as well. If there is a polyp, we can go for the polypectomy. If there is an endometrial hyperplasia under a vision, we can go for the endometrial biopsy if needed. Management. First thing, we'll mostly go with the medical management, that is to reduce the pain we'll give an NSAIDs, and depending on the severity of the anemia that is present, we'll go with the iron therapy treatment. And if it is an endometrial hyperplasia, main thing is that it is because of the excessive amount of the estrogen, so we will go with the progesterone only pills, and we can also give combined oral pills depending on the condition when we are supposed to give. And also the danazole and some injectables like DMPA, Depo-Provera, or gonadotropin antagonist and agonist, or intrauterine systems like LNG IUS. Next, management. If it is not controlling with the medical management, or if the patient is not willing for the medical management, or she is not fit for the medical management, or if there is any contraindications for the medical management, then we can opt for the surgical management. In surgical management, for example, if we suspect of any abnormal uterine bleeding, and if the endometrial thickness is high, then we can go for the DNC procedure, dilatation and curettage. Or we can also go for the endometrial ablation or the resection process. If there is any kind of increase of thickness or any fibroids are there, we can go for the myomectomies. If it is a submucosal, we can go with an hysteroscopic guided myomectomies. And or we can also go for the laparoscopic guided myomectomies if it is a subserosal. But subserosal mostly won't cause this abnormal uterine bleeding, but sometimes pain may be there during her menstrual cycles. And if the report comes abnormal, then or if the management is not going like if the patient is not tolerable for the medical management, then we can go for the hysterectomy, and we should send the specimen for the examination. Then we have to rule out if there is any malignancy is there. If any malignancy is there, we need to refer the patient to the oncology specialist. Thank you.